So, good morning everybody. We are talking about various generation, various types of rotator cuff repairs. So, traditionally speaking, conventionally, open rotator cuff repair was done, and this was done by the transosseous technique. What that means is you put tunnels through the humerus. The tunnel started from the insertion point and went up to the greater tuberosity, and over that we used to repair it like this. So this is called as a transosseous technique, and the transosseous technique leads to a very good opposition of the tendon on the bone. So this was done in the open technique. Okay, so the traditionally, conventionally, the most older technique you will think about the transosseous technique, and this was a good technique, but because it was a large area of the repair and you can do a good approximation of the cuff tendon onto the bone. So this was a transosseous technique. It is with SCOPE, people have tried to replicate the transosseous technique, and that's how the different stages have developed. Now when we talk about SCOPE, the first generation was the single row repair. So the single row repair is based on MA, that is called as a Mason-Allen repair. So the Mason-Allen repair basically is nothing but you have a double loaded anchor. So you pass 3 sutures through the tendon and repair one of them in a mattress fashion and one of them in a single fashion. Okay. So basically you pass 3 sutures through the tendon and one is free. So one suture is a mattress suture and one is a simple suture. You can have a modified Mason-Allen in which you can tie this first and the other second. That is, but by and large the concept remains the same. And this is still a very good technique for bursal surface tears, small tears, and I will say massive tears. For bursal, you have a 2 centimeter, basically the footprint is 2 centimeter. So if you have a 1 centimeter of the footprint which is exposed, a single row is enough. That will give you the desired closure. So bursal surface, single laminar tear, it is enough. Very small tears, you can still use it. If you have a tear which is less in dimension, about 1 centimeter, 2 centimeter in the dimensions, they still use it. It's good technique. If you have a massive cuff tear, then also single row is better, because single row will reduce the load or the stresses on the repair side. We want to do a tension-free repair. So this is again, so bursal, small and massive, these are the indications in my hand to do a single row first generation repair. So first generation does not mean that the results of first generation is inferior to the fourth generation. Okay, so by and large you can use first generation for these 3 good indications. Okay. Now the second generation is a double row, and this double row is with use of a regular anchor. You don't have to use any fancy lateral row anchor into this. So a standard anchor on the middle row, a standard anchor on the lateral row. Okay. So it is a misnomer. Some people consider that double row is not possible without a knotless anchor. No, it's not like that. You can do a double row with standard anchors also. So supposedly if you have a patient who is a cost content patient, you don't have, obviously knotless anchors are more costly than a regular anchor. And so if you want to do a double row and the patient is not affordable, then you can do what is called as a double row unlinked repair. Okay. So in that you put one medial row anchor and one lateral row anchor. These are both regular anchors. Okay. Use all the 4 limbs of the medial row. So do it in mattress fashion. And for the lateral row, you take simple on both the sides. So here you have taken 3 passages from an anchor. For a single row, Mason-Allen. For a double row unlinked, 4 passages from the medial row and 2 passages from the lateral row. Okay. So this is called as a double row unlinked repair. Now what is the advantage of this repair? Anybody can tell me? Yes, so this is the unlinked repair. So the advantage is the construct is independent. All the 4 anchors are independent fixation points, or all the 2 anchors, whatever anchors you have put, all the anchors have an independent fixation point. If one of the anchors gives away or fails, then also the rest of the anchors can stabilize the construct. Okay, so this is again a good technique. The negative part about this technique is it's difficult to do because you will have a lot of sutures inside. So technically it's little difficult to do because of the knot management and suture management difficulty. Because if you put like 3 anchors or 4 anchors, 2 medial row, 2 lateral row, then you will have 16 sutures inside and you might get confused. So that is the downside of this, but otherwise this is a good technique because this is based on a area healing. So single row is basically point healing and double row is basically the area healing. So the cuff will heal between the 2 anchors. Here it will heal around this anchor. Here the healing point is between the 2 anchors. Okay. So by and large the double row is technically good because it will give you a larger surface area of healing. Now it is the third row that is called as a double row and linked. So you pass the suture, pass all the 4 sutures through this. So again 4. So all the 4 sutures pass through the cuff, then you tie them and the knots you use on the knotless anchor on the lateral side. Okay, so this is the double row linked repair and this is the most commonly popularized cuff tear repair pattern which is popular nowadays, and people consider this as a conventional or a standard double row. Okay, this is not known to many, so most people will consider this as the double row repair. Now this is a very good technique. You get a very good repair, you get an area fixation. What are the downside to it?
One fails, everything.
So that is one. So it is a dependent construct, linked construct, dependent construct. And second,
Post.
third, one more drawback. So because you tie the knots here and then you use a push lock anchor here or a anchor which is a knotless anchor here. So this construct becomes an avascular area. So the biological healing is, some people say it's down. Strangulation because you tie the knot and this knot also you talk on the lateral side. So that area where the healing will occur, it is the blood supply will be reduced from all the sides. So that is the downside of using this double row link repair. Otherwise, I would use this particular technique and this particular technique for all my regular patients or a regular technique. Now the fourth technique is called as a tape lock technique. Now this is the recent innovation or recent advancement, and this is on the basis of use of non-sliding tape. This is very, very important. Non-slide tape. So if you want to use a tape lock technique, you need to have a non-sliding tape. What that means is that the tape which is used in that anchor should not be sliding. So with that, what you can do is you can use a knotless anchor without tying the medial row anchors. So you have 4 sutures supposedly. Normally you have 2 sutures and 2 tapes. You pass the tapes, don't tie them, and without tying them you use these tapes into the lateral row as a knotless fashion. Okay, so this technique is called as a tape lock technique, and this reduces the strangulation effect that is seen in the third generation. So it is postulated that if you use a tape lock, you will have a reduced incidence of a Choi type 2 tear, re-tear from a musculotendinous junction. So re-tears, if you talk about re-tears, so if this is your tendon, one anchor is here, one anchor is here, double row. If the tendon has to re-tear, this can re-tear from here or it can re-tear from here. So if it re-tears from here or if it re-tears by anchor pull-out, it's a good pattern of re-tear because you can re-repair it. Okay? So if suppose it tears from here, this is the tendinous part and this is the muscular part. So if it re-tears from here, then your repair will be, re-repair will be difficult. So for musculotendinous tears, the re-repair is difficult. So that is why this double linked third generation repair, also although it's a very good technique, can have some problems in some cases. So I strongly recommend two things if you are using this technique. One is don't over constrain or over tension your repair, that is number one. And number two, don't do a lot of knot tying and strangulation of the tissue. Leave some breathing space inside. So that is very important. Otherwise, in this tape lock, you don't have the strangulation effect because you pass the tapes and then you just compress it. So you will have at least the flow of blood which is coming from the other side. The other two sutures you can just add a stay suture later on. Okay? So this is by and large the generations or types of the rotator cuff repairs that we usually do. Any questions on this pattern? You can actually practice all these 4 types onto the models. So for this you need a regular anchor. For this you need a regular anchor. Regular anchor means any anchor which is double loaded and which is sliding. For this third generation you need a regular anchor and you need a knotless anchor. For this you need a knotless anchor and you need a tape lock anchor. So tape lock is essentially an anchor with a tape, and again when you taped anchors are also sliding. So you might get in some companies anchors with tape, but the tape is sliding. If the tape is sliding and if you are using a single anchor, then you can use this technique. But if you are using 2 anchors and then using 2 tapes from different anchors, then you cannot use this technique because you need to have a fixed point on which you can do a tensioning on the lateral side. So that is why if you are using 2 anchors, then it should be a non-sliding tape for tape lock. So this is technically called as a transosseous equivalent. So this is called as a TOE, transosseous equivalent repair. So this is the repair which is almost closest to the open transosseous technique. So nowadays arthroscopic transosseous is also available, but it has got some limitations. One is the technique. Second is in Indian patients there is a cheese cutting effect. So if the bone is osteoporotic and when you try to repair this can cut through and that can cause problems. So in Indian scenario, transosseous technique has not become very successful up till now with the present available instrumentations. So this is basically what you should know about rotator cuff generations. Okay.